I am Dr. Raj Rawal, for PG first year medicine resident at MMIMSR Hospital, Mula Nambala. We have an unusual case of autoimmune hepatitis. A patient, 57-year-old lady, presented with fatigue and abdominal distension. The patient has a history of type 2 diabetes mellitus with hypothyroidism and glomerulonephritis 10 years back. But we don't have a biopsy because the patient have a solitary kidney. Patient come with decreased appetite, fatigue of 2 months back and shortness of breath and abdominal distension. On diagnosis, we got hemoglobin 9.3 gram per liter, patient platelet was 1.2 into 10 raised to 9, patient TLC was 3.2, where neutrophil was 65, lymphocyte 331, monocyte 0 and eosinophil 4. Patient liver profile was in normal limit, bilirubin was 2 mg per deciliter, patient AST was 230 international unit per liter, patient ALT was 300 international unit per liter and patient ALP was 231 international unit per liter. Patient total protein was 6.9 mg per deciliter, which was in normal limit. Patient albumin, globulin also was in normal limit, like 3.4 mg per deciliter, and globulin was 3.5 mg per deciliter. Patient renal profile was also in normal limit. Patient electrolyte also in normal limit. Sodium was 137 milliequivalent per liter. Patient potassium was 4.1 milliequivalent per liter. Urea was 42 mg per deciliter. Patient creatinine was 1.1 mg per deciliter. Patient prothrombin time was 15 seconds and APTT was 30 seconds. After then, we confirmed by patient serum marker. Patient DNA was positive, finds pickled. Patient double-stranded DNA, anti-double-stranded DNA, which was 67 international unit per nanoliter, which was markedly raised. After that, we take a sample and give for the autoimmune marker, which was in negative, which was ASMA and anti-alchem was not detected. After that, patient 24 urine protein was 300 mg and patient urine microscopy, no RBC, no calcium. Patient was ascites and pleural effusion. We give a sample of ascitic fluid and pleural fluid. Ascitic fluid and pleural fluid was sterile and there was 210 cells per microliter in ascitic fluid. Neutrophil was 70 and leukocyte was 30. Protein was 3.2 mg per deciliter in ascitic fluid, albumin 2.7 mg per deciliter and SAC ratio was 0.7 mg per deciliter. In pleural fluid, there is a 90 cells per microliter. In pleural fluid, neutrophil was 90, leukocyte 10 and protein was 3.5 mg per deciliter. Patient 2T echo was done. The patient LVF was 57%. Ejection fraction was 57%. No right ventricular motion seen. No valvular lesion. No chamber or wall thickness. Chamber and wall thickness was within normal limit. Patient upper GI endoscopy. No esophageal varices seen. Patient ascitic and pleural fluid gene expert was negative. On evaluation, she was found to have a pleural effusion ascites, deranged liver function and high titer of ANA and double-stranded DNA. But patient other marker associated with autoimmune hepatitis were negative. After that, the viral marker and screen for hemochromatosis and Wilson disease, which was associated with this disease, were negative. After there was a radiological and histological findings seen in patient. In radiological, patient chest CT right side pleural effusion and patient abdominal CT shows hepatomegaly, ascites and solitary left kidney. After the histological finding, in H and E stain, we saw loss of lobular architecture, extensive macrovascular stenosis and Mallory Dank bodies. In reticular stain, show the variable fibrosis and distorted lobular architecture. After then we give a immunosuppressive therapy to the treatment, which was prednisolone as a azathioprine. Patient give a best response to this treatment and patient normalized liver function and improvement in symptom. We can say that the diagnosis of autoimmune hepatitis, which was covered by SLE, we have no symptom of SLE like rash or polyarthralgia, but patient have a 10-year back history of glomerulonephritis. Patient take a steroid a 10-year back, which give a best response to treatment. After then, we start treatment of steroid to the patient. And after then, polyserositis was present and the ascitic fluid had low SAC gradient, which along with a normal serum albumin coagulation profile, and the liver biopsy ruled out the liver disease and primary cause, leading to further support to the diagnosis of SLE. There was an unusual case of autoimmune hepatitis. The patient autoimmune marker was negative, but patient is markedly response to prednisolone and azathioprine, which show the patient have autoimmune hepatitis. Thank you.